So this next speaker, Rita Nguyen, I actually need to read a moment because I'm going to quote. I like people to tell me how they like to be introduced. In her case, I took this straight from her Twitter bio. So this is what she had to say for her Twitter bio. Design thinking, nutrition promoting, food insecurity slashing, nunchuck wielding, hospitalist and social justice junkie. Hard to beat, right? Hard to beat. But don't get distracted by the whimsy, right? This is someone who is fighting really hard to fight against inequity in underserved communities, and actions speak louder than words. So she is someone who, as a founder of the Pacific Free Clinic with Stanford, and as the medical director of the Healthy Foods Initiative at Zuckerberg, San Francisco General, all that while she oversees chronic disease and cancer prevention for the city and county of public health departments here in San Francisco. So please welcome Rita Nguyen.
Thank you. And I just have to say I'm so impressed to be with such an esteemed panel of speakers. And as you can kind of see from the other speakers, the definition of food as medicine is quite broad. And for my talk, I guess the frame that I'd like to put on it is one of health equity. And when I think about the epidemics of diabetes and obesity, that is an epidemic that is disproportionately borne on the backs of low-income communities and communities of color. And these are the same communities that have the highest rates of food insecurity. So I will frame my talk around food insecurity in health and how the concept of food as a medicine applies in that space. But at the same time, I also recognize that my spin on food as medicine is very specific to the healthcare system. As a public health professional, I very much so believe in the investment in communities. And when you're looking at upstream social determinants of health and you want to go even beyond that, you're looking at inverting power dynamics, as Dr. Brownwell said, that we need to empower communities and reverse the power dynamic. But what I'm going to focus here with this hat on is specifically the role of healthcare. And I know not all of you are healthcare practitioners, but in one realm, many of you are. Even if you are in the digital health space or work with pharma, in some respects you are in the healthcare space, and I'm hoping that some of these ideas might permeate your work. So, how I came to this work, I'm a physician. I see patients at our hospital now, but when I had a primary care panel, I would often see patients with high blood pressure and diabetes, and I would do as I've been trained to say, take your medications. Here's the prescription, but this is half of the equation. The other half is diet and exercise. And here's the diabetic diet. And I remember one of my patients came back and said, it's really stressful to me when you say that, because it's not as if I don't want to eat well. It's not easy for me to afford whole foods and fresh fruits and vegetables. And I don't really have ready access to a grocery store in my neighborhood. And I thought, that's really tragic. Here's another prescription for another medication, because that's all I had equipped. That's all I could do as a doctor. And it was just crazy making to me that how is it that with our healthcare system, if we're really trying to optimize health outcomes, all I can do is say, here's another prescription. And so I've always thought we just need to do better by our communities. If we're actually going to get people healthy, if we're actually going to change the curve on diabetes, it can't just be about medications, although that is part of it. And so for me, that's where the concept of food as medicine comes in. And I think it comes from this idea that folks are really seeing food as the solution, that it can enable and empower people to take health into their own hands and actively pursue health rather than just passively receive recommendations from the healthcare system. So that's where I see the power of food and linking it with healthcare. So as a bit of background, food insecurity may be a term that some of you are familiar with. It is defined as a lack of consistent access to enough food for an active, healthy life. Nationally, it's about 12% of households that are food insecure. And depending on your clients or your patient population, it may vary. For us at the Public Health Department, we have about 14 primary care clinics. It's closer to 65% of our patients are food insecure. So you can imagine why I can't control people's A1Cs when all I'm doing is giving insulin and medications. And there is strong scientific backing as to why there is this link between food insecurity and poor health outcomes. As you can imagine, if you are not sure where your next meal is coming from consistently, you have natural coping mechanisms. It's not about willpower or laziness or just not being motivated enough to eat well. Natural coping mechanisms is to eat high calorie dense foods that are low nutritional value. And so this inevitably worsens chronic disease like diabetes and obesity, which leads to more healthcare expenditures. You're less employable, you are earning less, and it just becomes this vicious cycle where more food insecurity begets worse health outcomes. The research is very clear that food insecurity is associated with poor health and behavioral outcomes in kids, and certainly among adults with health outcomes and healthcare use. Specific to diabetes, it's actually associated with increased risk of developing diabetes. So those who are food insecure are more likely to become diabetic than those who are not. And when you're looking at folks who already have diabetes, if you're food insecure, you're not going to be able to control your diabetes as well. You're going to go to the hospital more and have more physician encounters per year. In 2017, the American Diabetes Association, for the first time, wrote food insecurity into their guidelines for diabetes care, sort of highlighting the fact that food insecurity has to be addressed for diabetic patients. And I like this quote by the writer and author Wendell Berry, who says, "People are fed by the food industry, which pays no attention to health, and are treated by the health industry, which pays no attention to food." And I find this to be so true, and I particularly work in the healthcare sector, and so I just think that it makes no sense for our two sectors to be so separate. And we heard some of these themes earlier, that food systems and health systems need to be talking to each other if we're really going to uplift the health of communities, and food has to be part of that solution. When I think about the way we frame food as medicine in San Francisco, it's really in that space in between healthcare and food. And healthcare is bolded because the food systems are working. There's a lot that needs to happen in the food systems to really get at health disparities. But healthcare needs to have a role in that. Healthcare can be a powerful agent. It is well funded. We spend a lot of our GDP in healthcare, so there's potential there. And I think about a spectrum of interventions. And so that can start from even just on a very clinical level screening for food insecurity. And so you do just Google hunger vital sign. It's a 2-item screen. You ask 2 questions, and you can just find out whether or not people are food insecure. Then there's food programming, and then thinking about sustainable new funding sources and policy change. So thinking about payers, insurance companies, pharma, employers paying for food to keep people well. So getting a little bit more specific in terms of examples along the spectrum. So again, I mentioned screening and referring in healthcare settings. Starting to think about programming, about bringing food to healthcare and bringing healthcare to food, and I'll give you some specific examples. In the healthcare space, you've probably seen this in the news or heard about it in your communities about food prescriptions and vouchers and teaching kitchens and food pharmacies. And these are just ways in which healthcare are taking a stake in the issue of food insecurity. And saying that this is not just a problem for the food system, for nonprofits to be working on. You can also think about how you bring healthcare to food. So there are instances of diabetic food boxes at food pantries and food pantry staff referring people back into clinics. I also went to a Safeway once where it was a diabetes device company who was actually sponsoring walks with a nutritionist through the grocery store. So those are other ways that you can bring healthcare to food. And so specific in San Francisco, we have a Food as Medicine Collaborative. It's a multi-sector collaboration that involves healthcare, private sector, public sector, tackling this idea of how do we promote food as medicine? How do we get healthcare to have a stake in this? And our work is 3-pronged. We support food insecurity screening in healthcare. The programmatic elements of what we do here are food pharmacies. And so it's a 5-pronged model of access, education, skills, tools, and referrals. Because I agree with previous speakers, it's not just about giving food, it's about ways of empowering patients. And so we have the food. It's farmers markets, how people just take whatever they want. They're prescribed to come to the food pharmacy. There's nutrition education happening there, along with a nutritionist who's actually giving a cooking demonstration. So enabling people to actually pursue behavior change. We have tools, so we give out cutting boards, measuring cups, and crock pots for those who don't have kitchens. And then finally referrals, so connecting back to the food system so that people are accessing things like SNAP or food stamps and WIC and other resources. We're also working more and more with food suppliers so that we are supporting the local economy of farmers. and having more local and sustainable food, and developing a policy roadmap for sustainable funding sources. So that's thinking again about payers. And right now, California actually has a $6 million Medicaid pilot that is paying for food to see whether or not that will lead to decreased healthcare use and hospitalization. So there's actually a lot of movement in this space. For our food pharmacies, we are now expanding to 8 as of this summer. We'll probably have 9 by the end of the year. What's great about that is that that would represent 4 different health systems in our city that have championed this idea of food as medicine, that we will take a stake in this. This is something that is a problem that healthcare needs to own, or be part of at least. And so just some outcomes from our work, that 96% of the patients have increased access to healthy food and adopted healthier eating practices. This is of those that have been surveyed. We serve about 1,000 individuals a year. Not everyone fills out our survey. The great benefit of being tied to a health system is we can actually see the health outcomes. So we're seeing that 65% of our patients who come to 3 or more of our food pharmacies have actually a statistically significant decline in their blood pressure. And it's worth noting that I started off this talk thinking, giving the framework of equity. So our food pharmacies are actually designed by our patients, with our patients, particularly to serve our Black African American patients in San Francisco, where there is this great disparity gap with hypertension control. We had first started with diabetes. We're trying to move the system back to address diabetes, but their thing right now is hypertension. My takeaway ask of this group and audience is, what can you take back to your work around food insecurity? How are you accounting for food insecure individuals among your clients, among your patients, among the folks who are accessing your services? Are you asking about food insecurity? Are you tailoring your services and thinking about how food insecurity might be affecting their ability to control diabetes? So that would be my ask of the group. So thank you for your time and attention.